Hello, everyone. Welcome to our Core Kidney Grand Rounds webinar. My name is Alicia Chowdhury, and I am a co-president of the Bruin Beans Health Club.
Hello, everyone. My name is Arif Tandon, and I'm the fellow co-president. Broom Beans is the undergraduate chapter of our parent organization, Core Kidney, here at UCLA Health, and we work to embody the core values of clinical excellence, outreach, research, and education to bring kidney health awareness to the greater community.
This webinar is an example of the outreach we conduct under Dr. Anjay Rastogi. He has taught us how to build bridges between the clinical world and lived experiences. We will now pass it off to Dr. Rastogi to introduce our presenter for today.
Thank you. Thank you, Alicia. Thank you, Arif, and thank you, Evan, as well. So welcome, everybody, to our special Grand Rounds. My name is Anjay Rastogi, and today it's really my distinct honor and pleasure to introduce our speaker for the Grand Rounds, is Dr. Jhaveri. And I'll try to summarize his intro. It's pretty long, but just hitting some key points. So Dr. Jhaveri is Professor of Medicine and Associate Chief in the Division of Kidney Diseases and Hypertension at the Zucker School of Medicine at Hofstra Northwell. He completed his residency training at Yale University New Haven Hospital in internal medicine, and then did a fellowship in nephrology at New York Presbyterian Hospital Weill Cornell campus. His clinical and research interests are in glomerular diseases, AKI, and cancer-related kidney complications, or onconephrology, and that's the topic for today. He's one of the founders of this field way back in 2009, and since then has created and led the American Society of Onconephrology, ASON for short. He's a world leader and authority in this field in nephrology. In addition, he's the founder and program director of the Galdi Fellowship of Glomerular Diseases and Onconephrology at Northwell Health. He's a columnist for the ASN Kidney News for the section called Detective Nephron. His interest in nephrology education is vested in using creative ways of teaching nephrology to medical students, residents, and fellows. He has published on onconephrology and also in using social media and other innovative tools, games, concept maps, role playing, and creative writing to make nephrology a fun and exciting field. He has conducted numerous faculty development seminars locally to teach these techniques. He's a teaching-oriented blog called nephronpower.com. Currently, he is now the editor-in-chief of the ASN Kidney News and has won several awards at both local, national, and international level in nephrology and medical education. So Dr. Jhaveri has a very, very impressive resume, as I said. But more importantly, Dr. Jhaveri is a dear friend of mine, dear friend of Core Kidney, a great mentor, and just an amazing human being. And like I said, it's really a true privilege and honor for us to have him over here. And Alicia and Arif mentioned our core founding principles. So if there's one person who embodies all those core principles, is Dr. Jhaveri. Now we want to keep this program interactive. This is the time to ask questions. So please put those questions in the Q&A box or the chat box, and we will do our best to answer them at the end. If we can't get to all the questions at the end, we will make sure that Dr. Jhaveri answers and we email them back to you. So with that, Dr. Jhaveri, welcome.
Thanks, Sanjay, and thanks to the Bruin Beans Health Club. I had a nice time chatting with you guys earlier. Thanks for organizing this and a very kind introduction. So my task today is to really talk to you about what is onconephrology. You guys know what nephrology is, at least. It's basically the work of the kidney. But what is onconephrology? That's what's going to take you through the entire field in the next 1 hour. What's at least the big picture view. Okay, so we'll get started. Hope you can see my slides and can hear me okay. This is a disclaimer slide from the core kidney, which they talked about. And my disclosure is really, besides what Anjay said, that I am the ex-co-president and founder of the American Society of Onconephrology, and none of my consulting agreements are related to the talk today. They're related to more glomerular diseases, not on onconephrology. So, So today, basically, I'll talk about an intro to what onconephrology is, a little bit of a history of the field, and then overview of various clinical syndromes that make onconephrology, and then the future and education of onconephrology. How is that in the next few years and decade going to look like? For the undergrads in the audience, which might be majority of you guys, nephrology as a field is under internal medicine. So after you finish your undergrad, you go to medical school. In medical school, you decide you like cutting or not cutting. If you like cutting, you go into surgery. If you like non-cutting and just to see patients, then you go into medicine or pediatrics. And pediatrics, if you like kids, and if you don't like to deal with kids, then you go into adults. Once you do internal medicine, which is a 3-year residency, you do 2 years of nephrology fellowship. And that's what nephrology, becomes. So you become a nephrologist after 5 years of residency slash fellowship. But what is onconephrology is slightly different, and I'll get into that. But I just want to give you a framework of where do where this whole process is. Cancer and survivorship. So people nowadays are living much longer with cancer because the oncologist, which is another field within medicine, which is another 3 years of fellowship after 3 years of medicine residency, the oncologists have really pioneered and done really well with treatment of cancer. Their treatment has led to more people surviving cancer and living with complications of that cancer or the cancer therapy. And that's basically what's called these days cancer survivorship. This didn't exist many, many years ago because patients were not doing that well with cancer. Now, and at least in 2020s, we're doing much, much better. That has led to specialized fields within oncology called onconephrology. So dealing with cancer complications to the kidney, the cancer complications in the heart is called cardio-oncology. Um, the oncoendocrinology is endocrine complications, rheumatology, rheum complications, pulmonaries, lung complications. You can see here the cardiologists like to put themselves first, just FYI. Everybody else follows the trend of onc first because these are cancer patients. So why onconephrology? And onconephrology is when you deal with all these complications in the cancer ward that leads to a cancer-related complication in the kidney. So a kidney disease, AKI, or acute kidney injury that happens in a cancer patient is AKI, a new glomerular disease. It could be complications of chemotherapy or these novel immunotherapy agents. It could even be something as myeloma and amyloidosis, which can also affect the kidney. So that is what you see in the bread and butter onconephrology, and even electrolyte disorders like hyponatremia or hypercalcemia. But there's also this interaction of chronic kidney disease and cancer. So if you have chronic kidney disease, could it be coming from a kidney injury that happened because of the cancer? Could it be coming from cancer-related factors, like something infiltrating the kidney? Could it be just patient-related factors, or maybe the therapy itself? A lot of things can lead to chronic kidney disease. And it could be vice versa too. Chronic kidney disease over time, as the GFR and kidney function drops, the risk of cancer goes up. So it is all intertwined, and these two fields can get a lot of time together. So what is onconephrology and why in the history of the creation of the society? So let's go back in 2007, 2005, 2000. It's really when some review articles started coming out on cancer complications of chemotherapy or cancer. The first textbook by Dr. Eric Cohn was published in 2005. And some, education was just review articles, minimal original research. So there was some sessions here and there people were doing. I would say the cancer hospitals in the world, like Sloan Kettering, Dana-Farber, and MD Anderson, that are standalone cancer hospitals, they had nephrologists hired by them. So but just by being hired there, they were onconephrologists, right? Because he worked only in a cancer hospital. Every other hospital around the world, in the country, which was an academic center with a cancer division, really didn't have dedicated onconephrologists because they were hired just part of the division of nephrology and just taking care of patients. And maybe they saw some cancer patients. Hope that makes sense. So in it's 2009 or so, the awareness of review articles started going up. And the American Society of Nephrology did their first ever session on this topic. It was not till 2014 that original data started coming out on talks. And like rather than review articles, we were seeing more original research. It's 2017, the first journal of onconephrology was created. And then around that time, the ASN and other societies were forming to have symposiums on this as original investigations started coming out, and other countries started having local societies. Then there were other journals that had sections of onconephrology. The first textbook, four more textbooks came out, and then the International KDIGO guidelines of onconephrology meeting in 2018. So when all this was happening, we said, this might be the perfect time to form a society of onconephrology. And it was in 2022 then four of us actually formed the American Society of Onconephrology. It took us a lot of time to come up with that logo, and we were very proud of that because it was actually something that we really envisioned over decades that came to fruition. So what is some of the syndromes in onconephrology? One of the first ones is acute kidney injury, which is renal failure for some people. And that happens in a lot of the cancer patients. Could it be, and anytime the patient gets acute kidney injury, their risk of like mortality just goes up. Okay, so there is critically ill patients with cancer, that kidney injury, they require dialysis, that their mortality goes up. The causes are here, it can be very different things. You can, again, anytime you see renal failure, you have to think pre-renal, post-renal, and renal. And you can see here that throws in some other causes within the causes of renal, like such as thrombotic microangiopathy, infiltration of the tumor, obstruction from the cancer, and then treatment-related injuries can happen. And then finally, metabolic complications that can cause kidney failure, like hypercalcemia can cause AKI. So it is like any other patient you see, you have to think about the regular pre-renal, renal, extra-renal, but now you have to throw in the milieu of the cancer complications that could be also causing the AKI. So here, if you look at the nephron, you can see from the glomerulus all the way to the collecting duct, and these are all the drugs that can cause kidney injury. You can name a drug, and I can tell you that it can affect some part of the kidney. So you can learn so much nephrology from onconephrology. You have drugs that can affect the glomerulus, the endothelium. It can affect the proximal tubule from the loops to even the collecting duct and the interstitium that's around it and the tubules that are around it. So you can cause various different types of injury just from different cancer therapies. And, the New England Journal of Medicine now is the New England Journal of Oncology because the new drugs keep getting bigger and bigger, and there's drugs coming out almost every week in the oncology world compared to the other subspecialties within medicine. So to keep up with these toxicities is very, very hard. But commend, the oncologists are really commendable for this, to really push the field so fast that the cancer patients are living longer with such amazing therapy that they've come up with. So the risk factors for kidney injury are the usual, the volume depletion, other kidney toxic drugs you get, obstruction, age, having another known kidney disease in the past can cause toxicities. So what I'm going to talk about next is some of the common toxins that we see in the cancer world that can affect the kidney. Okay, we'll start with some tubular interstitial toxins that affects the tubules and the interstitium surrounding it, and how it can cause something called ATN, which is tubular injury, or interstitial nephritis, or swelling of the interstitium from these toxins. The classic ones, you maybe heard of these, the nephrologists definitely have, and the oncologists, the platinum-based agents, which is cisplatin. That is the classic old world chemo that is kidney toxic for years and years, and people still use it because it is such a great chemotherapy agent. There are other ones like pemetrexate, nitrosoureas that also are kidney toxic, not as high as platinum. Okay, so here's sort of a schematic. I like pictures better than words. It kind of talks about the different renal injuries with standard chemotherapy agents, the ones that everybody used for years and decades and still in use. You can either get tubular toxicity, and you see pathology pictures here causing tubular toxicity. You can sometimes get vascular toxicity or affecting the endothelium and the red cells around the kidney, which is called thrombotic microangiopathy. You can get interstitial nephritis, which is the allergic reaction in the interstitium causing like edema, or you can get a glomerular pathology. You can get like glomerular disease from one of these drugs. Very rare, but the most common is ATN or interstitial nephritis. Cisplatin, everybody should know this. It is something that either you see on a day-to-day basis or you have a question on the boards, okay? Even on the medicine boards, perhaps. And it can cause renal failure, hypomagnesemia, some hyponatremia, and some of the other things. It is classically known to be nephrotoxic. And what it does is, this is cisplatin here. It is coming, and we're going to compare it to some of the other ones like oxaliplatin and carboplatin, which are also platinums, not as nephrotoxic. But cisplatin enters the kidney tubules and does not leave and causes some sort of oxidative stress. And when you see figures like this, which cause a lot of question mark, means people don't know exactly the mechanism and actually causes some DNA damage leading to toxicity. Okay. I think the bigger thing we have realized is what keeps the cisplatin in the tubule is magnesium. If you have good amount of magnesium around, it quickly kicks it out and you don't get as much cisplatin toxicity. But if magnesium is low, then cisplatin stays in your tubules too long in the kidney, causing toxicity. So hypomagnesemia is one of the biggest culprits of cisplatin nephrotoxicity. So this is probably, I want to just highlight a few recent studies for everything we talk about. This is a large academic center study, probably the largest study on cisplatin-induced AKI that was published in 2024. And it looked at big academic centers, including ourselves, that received cisplatin and found AKI within the 14 days. And what were the risk factors? Age, hypertension, diabetes, cisplatin dose, and some of the other things up here, magnesium being one of them, and some of the other ones over here. That led to creating a calculator that can predict if you're going to get acute kidney injury from cisplatin. Okay, so if you had kidney injury with cisplatin in a very high score, your risk was higher in terms of mortality. Okay, because you need dialysis or things like that. But this calculator now is available, it's validated. And for example, if you put all the numbers in this one patient where you have a normal magnesium, a normal platelet count, in a younger person with a low cisplatin dose and a normal creatinine, your risk of kidney injury is much low. But if you have a low magnesium level, you have an older person, higher cisplatin dose, baseline CKD, your risk of a kidney injury goes up. Yes, it's probably rocket science. You don't need to do a calculator to figure this out, but nobody had done this. Nobody had given the actual predictors and put it in a calculator. So now your oncologist looks at this and says, you know what, your risk is high. Maybe I should make sure nephrology sees you before giving the chemotherapy. Or we should think of another option that's not going to be kidney toxic, or at least replete your magnesium maybe. Could that be could be a possibility? Yes. So is IV Meg effective in preventing cisplatin AKI? And it was. In the same study, in a subset analysis of the largest cohort to date, a magnesium replacement prevented kidney injury from cisplatin. So this is why onconephrology is important. Nephrology brings in a different perspective now that can save this patient from getting a toxicity by preventing it by giving a simple drug like magnesium. Okay, and that wouldn't be possible if we didn't get all together and create these large studies because these are rare diseases. You're not going to get the numbers by doing a single center RCT. So there are other chemotherapy agents that can cause toxicity. I'm just going to name a few. You don't need to know these things, but they're just all around here that cause toxicity. And you can see bendamustine, there is mitomycin, there's doxorubicin, there is streptozocin, ifosfamide. They all cause some form of kidney injury. So knowledge of this is important. Do I know all of them? No, but if I don't know, I look them up and see what the incidence rate is, or at least the mechanism. And sometimes you might have to connect those dots when you see a patient. So then we're going to talk a little about immunotherapy. or cancer immunotherapy. So what is immunotherapy and how is that different from the chemotherapy we just talked about? Okay, so this targets the immune system and not the tumor. Okay, so these are some of the sort of examples of these drugs, and I'll explain to you what exactly I mean, but I just want to give you some names as a context. So ipilimumab, nivolumab, and pembrolizumab are the three that are the classic, ones that most people use in immunotherapy. Okay, what is immunotherapy? So this is, think of if you have if cancer are weeds, or so you have weeds growing in your garden, and that's cancer. So one of the ways to get rid of weeds is pluck them out. That's surgery, right? Surgery removes cancer too. Certain surgeries just remove the mass and you're done. That's one way. You can use something called a sprinkler, right? You create a drug that sprinkles all around and the weeds die. But when you use a sprinkler, which is your standard chemotherapy, you're going to affect other cells as well. And you're going to have side effects of hair loss and things like that. Okay. Okay, so fine. Well, let's do targeted therapy. Let's just only spray the weeds. And that's the sprays. Yes, but that can also have off-target effects. Okay, and that's called targeted therapy. That's another form of therapy that oncologists have come up with. And finally, you know what? Let's just not do any spraying. Let's just change the soil so that the weeds don't grow, or the soil becomes stronger so the weeds get attacked. And that is immunotherapy. You change your immune system to attack the cancer. You're not giving anything external that is, it's damaging the other organs. So the immune system is required, right? So maybe you don't know this, but your immune system is required to fight cancer cells. Okay, when you get bacteria infection, viral infections, your immune system fights that. But the same way, if a cancerous cell is in your body, the immune system fights it off also and keeps things under check. And these are immune checkpoints that keep those things under check. Okay, so if you have a cancerous cell out there, and you want your T cells, which is your activating of the immune system, to attack that cancer cell, that will keep attacking the cancer cell. But the immune system doesn't like constant activation of T cells. They like to put some brakes on that so you don't get too much, you want some policing of that so you don't get side effects. And that policing are these checkpoints. They're like a checkpoint. Let's not go crazy attacking the cancer cell or the bacteria. We want some controlled chaos. So these are your police cells. These are police checkpoints. So CTLA4 and PD1 are these checkpoints. So the oncologist figured out, if I block these checkpoints, so you don't have any negative effects of any checks, then your T cell is constantly activated to fight the cancer. So there's no more checkpoint. So you're removing the inhibition. So you're releasing the brakes. So it's constant acceleration. That is immunotherapy. So you're releasing the brakes and removing that negative. So you have so much, constant activation of the T cells that you actually can attack and kill the cancer. Okay, so that's what immunotherapy is in a nutshell. But if you activate the immune system, you definitely are fighting the cancer, but you can also cause other itises to kind of act up. So when you activate the immune system, you get inflammation in the rest of the body, maybe. So the most common is colitis and dermatitis. You get a skin reaction, an inflammation, you get, colitis or inflammation of the colon. And the same way you can get nephritis. So there is side effects to these immunotherapies, but it's something that is still revolutionized on cancer care. So, for example, this hypertensive patient on proton pump inhibitor for acid reflux get lung cancer, and she started on pembrolizumab, which is immunotherapy. The creatinine goes from 1 to 2, and the kidney biopsy here reveals this, these cells coming into the kidney. There's so much swelling. It's all the interstitium that's swollen. That's interstitial nephritis or acute interstitial nephritis. Your T cells just got invited to attack the interstitium because you just revved up the immune system, right? Because you wanted to attack the cancer. But as an off effect of that, you got these T cells to attack part of the kidney called interstitial nephritis. And the first study to kind of look into this showed that the incidence of this was around 3% when you give a drug. And the most common risk factor was being on a PPI, because PPIs, or proton pump inhibitors, are the number one cause of interstitial nephritis, even in the non-onconephrology world. So it sort of like acts like a hapten. You opened up the immune system and you already have a drug that can cause the nephritis. You just like a second hit and triggered the whole thing. So this is again coming all together in a multi-center study, looking at all the centers that had cases of checkpoint inhibitor acute kidney injury. Dr. Gupta led this from Harvard, and you can see here we had to compare with controls who did not get kidney injury. And it turns out that these patients get other renal manifestations, and most of the biopsy findings were acute interstitial nephritis. PPI, other itises, and having CKD was the biggest risk factors. And giving steroids early to calm that inflammation down really helped the patient and to avoid dialysis. Okay, so it is now well known that these drugs cause interstitial nephritis. There is the oncology guidelines and nephrology opinion and some guidelines recently. The oncologist will hold the therapy and give steroids, and if there's no improvement, we'll call nephrology. Nephrology likes to get a consult first, get a biopsy, and then do steroids only if it shows AIN. I agree with the oncologist more, because how many doctors are you going to send these patients to? Let's try the steroids unless there's a red flag that there's no cause of acute kidney injury other than the checkpoint inhibitor. And then if that doesn't improve, then send them to nephrology. It matters because when you have kidney injury in these patients who got checkpoint inhibitor, they actually can cause a mortality, downward effect. So again, anytime you get acute kidney injury, it's going to affect mortality. So that's been well shown in multiple studies. You can get rarer diseases with checkpoint inhibitors like glomerular diseases, and these are even rarer than the immunotherapy, and they are even harder to treat. So these are like autoimmune diseases like vasculitis or podocytopathies like minimal change disease, and to give treatment for these in a cancer patient is even harder, to give them immunosuppression, because now you want to calm the inflammation down with an immunosuppression and not activate the immune system, which is counterintuitive for someone who needs cancer therapy that's activating the immune system. So that's why these patients don't do that well. They're dialysis dependent and they have higher mortality when they have this type of disease. Okay, so this is where nephrology really meets the onconephrology world, and even glomerular disease part, which is another hat I put on. So in general, these checkpoint inhibitor AKI is the hot topic right now in onconephrology, and we just kind of went over some of the biopsy findings and how it's hard to find and treat these. I'm not a big person who quickly biopsies these patients. I think treatment is more urgent. The sooner you treat them with steroids, the faster they recover. These checkpoint inhibitors cause weird electrolyte disorders too, because they activate the immune system. So one of the things they activate and can cause is hypophysitis and adrenalitis. So you kind of inflammation of your pituitary and your adrenal glands, which can cause hyponatremia or low sodium levels. So it's a very rare cause of that, but it can also cause other electrolyte disorders that you be aware of. For example, it can cause sarcoid-like granulomas, causing sarcoidosis, causing hypercalcemia. So again, as an onconephrologist, I'm aware of these things, but a general nephrologist might not think about the other rare causes of immunotherapy-induced electrolyte disorders. So just giving you that other perspective. So here's another case. This is a 75-year-old female with ovarian cancer, has now proteinuria, so protein loss in the urine, not AKI. She gets this complicated treatment with paclitaxel carboplatin and then gets surgery. Then she has new lymphadenopathy. She gets carboplatin again, and then she receives something called gemcitabine and carboplatin, and then gives this drug called Avastin or bevacizumab since 2019. And then you see some proteinuria happening. She's still on Avastin, and the blood pressure is starting to go up. She has some swelling in her legs, and she has a total of 14.9 grams of urine protein she's leaking. That's pretty high. We should not be leaking any protein. A creatinine is completely normal. So we see some blood tests and we find that, she has really nothing that stands out that we are concerned about. So everything is negative from a blood work standpoint. A kidney biopsy, here you can see the glomeruli. Those are your tubules. The glomeruli don't look normal. There's something there. It almost looks like cauliflower shaped, and the vasculature doesn't look great either. And you can see here, this is the endothelium that is very damaged, and the blood vessels around it as well. But the tubules look okay, but slightly damaged. And then when you stain, it stains for fibrin, and there is this extra layer that has started to form in a more high power electron microscopy. And this is what we call thrombotic microangiopathy, or what we would call like vascular damage. That's probably from one of the drugs. And the drug is Avastin, okay, or bevacizumab. That's a targeted therapy. That's one of your sprays, not the sprinkler and not the immunotherapy. That's another type of therapy that cancer doctors use, and it causes a syndrome called thrombotic microangiopathy. You probably heard of HUS and TTP, but TMA or thrombotic microangiopathy is sometimes renal limited or systemic, and it is when your blood vessels get inflamed and start damaging and leaking, and you get endothelial cell injury. The problem with this is diagnosis, and this is where I think, again, onconephrology is helpful. Here's your diagnosis of TMA, which is the elephant in the room. Your oncologist is looking at the platelets dropping, hemoglobin dropping. The cardiologist is called because the blood pressure is going up, and they're just checking the blood pressure, adding medications. Finally, someone checks a urine, there's protein in the urine, and the nephrologist is following the hematuria and the proteinuria. But nobody's putting the whole thing together that this whole trend of upward hypertension, downtrending platelets, downtrending hemoglobin, proteinuria is just thrombotic microangiopathy. But the elephant in the room is being missed because people are looking at different parts of the elephant. And thrombotic microangiopathy, for those who don't know, is a syndrome. It can be caused by multiple different causes, from drug-induced, which we're talking about here. It could be genetic. It could be complement mediated. And sugar toxin is a big one you probably heard of, causes diarrhea, and then the thrombotic microangiopathy, and then even vitamin B12 deficiency can do that. So in the kidney, in the cancer world, cancer itself can cause TMA. The drug here that we can talk about is bevacizumab, but gemcitabine can cause it too. A lot of these targeted therapies, the sprinklers, can cause thrombotic microangiopathy. And then if you get a stem cell transplant, you can also get thrombotic microangiopathy. So it's a very common diagnosis we talk about in the onconephrology world. And what happens is you get these drugs called bevacizumab. It's a VEGF antibody or a VEGF trap, or these VEGF receptor antibodies, or these tyrosine kinase inhibitors, which have an anti-VEGF effect. VEGF is required for your vascular growth. It's a growth factor. If you block it, you get endothelial injury and thrombotic microangiopathy. Okay. The way we learned about this was actually from pregnancy. When you get preeclampsia, you have a factor that also blocks VEGF and causes high blood pressure, protein leakage, and all the findings of preeclampsia. So when TMA or these drugs were described first in cancer world, they were called preeclampsia in a man. So preeclampsia is a type of TMA. It's just in this case, it's caused by a drug. In preeclampsia, it's caused by a factor called sFlt1 that causes VEGF to be depleted, causing the pregnant woman to have hypertension and proteinuria, which is exactly what we see here. Okay, so hypertension is an endothelial injury that causes high blood pressure. It's not the high blood pressure that's coming first. Blood pressure is a symptom of the disease. Okay, and then the proteinuria is when you get damage in the podocytes and the endothelium as well. So treatment is really to stop the drug, but sometimes we need to keep the drug on to treat the cancer, and then we give the medications to control the side effects of the hypertension. So again, cancer drugs can cause endothelial injury, and that's a very common side effect of a lot of these anti-cancer agents that kind of you will see as we talk about onconephrology. So it's one of the common ones we see as a pathology report. Here's sort of the summary of some of the drugs that can cause TMA. Some of them cause a direct toxicity of endothelial injury. Some cause immune-mediated toxicity of idiosyncratic. And here are some of the names of these drugs that can do that. Now, what's the most common one? And this recent study showed the most common drug to cause TMA is carfilzomib, which is a drug used to treat myeloma. And it's actually in the most number of cases reported, followed by gemcitabine, mitomycin, bevacizumab, and bortezomib. So we saw the case at gemcitabine and bevacizumab. Carfilzomib is a myeloma case. So in this study, it was found that the proteasome inhibitors like gemcitabine had the highest cases, and the highest for fatality was seen when you get checkpoint inhibitor thrombotic microangiopathy. So gemcitabine had the lowest fatality rate. So some of them, you stop the drug and the patient really improves. But some of them, once the damage is done, it's hard to convert back into even after the drug is stopped. So next case, this is a 35-year-old female with breast cancer. She's on letrozole and this drug called abemaciclib. I guess oncologists can make these names very hard to pronounce. For 3 months, it's effort for evaluation of abnormal kidney function. But creatinine before starting all this was 1, which is normal. Now it's 1.4 after 4 cycles. The urine is completely negative, no blood in the urine, no protein, and she's not on any nephrotoxic medications. Blood pressure is also very normal. She's young, really no other major problems. So the oncology team is concerned about the AKI and stop the drug. Repeat labs after stopping the drug, the creatinine is back to 1. After you re-challenge the drug, it goes back up to 1.4. So clearly something the drug is doing, right? So what do you do next? Stop the drug, continue the drug and see how much higher the creatinine can go, or check a cystatin C-based GFR. So this is something that maybe some of the general nephrologists can associate with. But the GFR equation that we use in general, in most part of the world, is creatinine based. And creatinine is not a great marker in general. We don't have a troponin for kidney disease, but it's not a great marker. Now, if you have low muscle mass, if you have a very young person or a very old person, frail, your creatinine might be falsely low, but you truly have kidney disease. Or you could have a very muscular man or a woman, and their creatinine is going to be high because muscle breakdown is also increases creatinine, and that's part of creatine. Or someone's taking creatine supplements and the creatinine goes up, but that's a false elevation because their true GFR or kidney function is normal. So as a result, we have other markers such as cystatin C, which is not affected by these interpretations. And we use that cystatin C-based equation to check a true GFR. Interestingly, some of these drugs that oncologists use can also affect the secretion of creatinine in the kidney. And that leads to a false elevation of creatinine. So it's really, if you check the cystatin C-based GFR, this person's GFR was 95, as opposed to 50 if you checked the creatinine base. So the true function was completely normal. So the interpretation was incorrect. So these drugs, what they do, some of these drugs are, the mechanism of this drug is CDK4/6 inhibitor. They basically block the secretion of creatinine in the MATE1 OCT2 transporter in the tubule, so the creatinine value falsely goes up. It's really not a kidney injury, it's just a false elevation. So if you use a cystatin-based GFR, you will be completely fine, and you should not be stopping a drug that actually is helpful to that patient. So there are a lot of these cancer drugs that are coming out. These are some classes here that cause a false elevation in creatinine or pseudo acute kidney injury. So not a true fall in GFR because they inhibit these mechanisms. So a rise in creatinine reflects a transport inhibition, not reduced kidney function. You have to verify that with a cystatin C. So That's another interesting part we saw. Now, onconephrology also includes myeloma, and myeloma is a disease of the bone marrow of the plasma cells, and that is known to cause kidney effects. Like 30 to 40% of myeloma patients have kidney involvement of myeloma, and it can involve in different ways. You affect the tubules, you can cause hypercalcemia, volume depletion, or it can cause glomerular diseases that can affect the kidney. So, that's a whole nother area of onconephrology that, is some people just specialized in heme, myeloma, amyloid related kidney diseases. Then there is the electrolyte disorders in the cancer patient. So you can get hyponatremia, you can get hyperkalemia. The interesting thing about our cancer patients, some of these patients who have CLL, they have false potassium elevations. You get hypercalcemia, which is high calcium levels from multiple malignancies, hypophosphatemia from high FGF23 production of certain cancers, and then tumor lysis syndrome. But in a lot of the cancer patients, again, we see pseudo electrolyte disorders. And this is a nice table that summarizes some of the pseudo electrolytes. So it's again, just like the creatinine was not real, you can have electrolyte disorders that are not real, and you might falsely treat them, especially the potassium, that being pseudo from thrombocytosis, from CLL. You can see a lot of myeloma patients get a false elevation of phosphorus and potassium. So a lot of different ones that are out there. And then you have this sort of hyponatremia, which is the most common electrolyte disorder in the cancer patient. And you have to think the old way, how we always think about hyponatremia, the serum osm, the urine osm, but we have to put in the cancer diagnosis now and the cancer causes. So sometimes as a general nephrologist, you might not think of some of these other causes that might be happening, especially the endocrine causes with some of these drugs, and you might miss it. And you might miss a diagnosis that require treatment with steroids. So that's why another place where onconephrology comes into play in terms of treatment and changing the way you think about certain common electrolyte disorders. And why does the onconephrology hyponatremia matter? Because hyponatremia in cancer affects survival. The worse your sodium level, the survival is worse. It affects cost, length of stay, duration of cancer remission, response to therapy, and overall performance status of the patient. So it does matter, these electrolyte disorders. And hypercalcemia malignancy is another whole area of interest to a lot of onconephrologists because that is so common in the hospital that we see, and you need to know what's causing it. Is it PTHRP mediated? Is vitamin D causing the high calcium? Is it PTH causing the high calcium? Is it some ectopic production of something? Because the final common pathway of all of this is destruction of bone and fractures. So you need to know the cause and treat it accordingly because not all of these patients will respond to your standard hypercalcemia treatment. So again, another diagnostic help if you know this literature better in terms of hypercalcemia malignancy. The other big category in onconephrology is our pharmacists and dosing. So if you have chemotherapy agents and you have a patient with chronic kidney disease, or you have a patient on dialysis or peritoneal dialysis, how are you going to dose that chemo? What formula are you going to use? How are you going to give the chemo pre-dialysis, post-dialysis? What is the data on each one of those drugs? It's a big challenge, and that's a whole nother area of expertise and research. I'm sure if you go on UpToDate or open evidence, you will be able to get the answer. But what is the data behind that? What is the reference behind that is important. Most of it's case reports. And the special groups that are now forming, pediatric onconephrology, transplant onconephrology, so dealing with a transplant patient that's getting now cancer and chemotherapy, kidney transplant, palliative care onconephrology, and then the whole field of oncohypertension, drug-induced cancer hypertension. So here's an example of the degree of hypertension you see with cancer therapy. Look at some of these drugs. Some of them have almost as high as 90% of them cause hypertension. Okay, so there is mechanisms behind it. And how do you treat that hypertension that's being caused by a cancer therapy? And then once the therapy stops, they quickly go down. You have to stop the treatment of the hypertension. So it's very important that you pay attention to some of these side effects as well. This is a slide to kind of show you the transplant onconephrology. That is another big player. Like what happens to patients who are on dialysis, who had a history of malignancy, and now they're on the transplant list. How long do they have to wait? What happens when you get a cancer after kidney transplant? And then can I give this patient immunotherapy? Will it activate the immune system and reject the kidney? Can I give them standard chemotherapy? So a lot of these questions are now popping up as new cancer therapy comes about. So here's sort of a curriculum that we think is important for onconephrology if you were to do an extra year of training or you want to do something within your regular fellowship. It should really include all of these: electrolyte disorders, glomerular diseases and malignancy, cancer-related complications, the acute kidney injury, chemotherapy complications, paraproteinemias, thrombotic microangiopathies, bone marrow transplantation complications, tumor lysis syndrome, dosing, obstructive kidney disease, and then the disease after nephrectomy as well. So this is sort of the curriculum. Here's interesting thing we started in 2019. So a few of us got together and created a WhatsApp chat of all the onconephrologists that we could gather around the world. And slowly that increased to now it's up to 300. But we studied this when there was 118. And what was it used for? We were asking questions about cases. We were talking about research ideas because there's so much less information out there. So we had actually one of the high school students at that time was rotating with us, was applying for undergrad. We asked them to look into the qualitatively what was when you look at the chat, what we could find. So using a qualitative survey and a qualitative analysis, we did a thematic analysis of keywords and themes of what arose from the chat. And we found that 92% of all the questions were asked were answered. Okay. And 78% of the people in the chat were around academic physicians, and very few had less than 5 years of experience. Only 42 had an onconephrology clinic. After Up to Date, this chat was the next best resource to get help for tackling tough cases because the authors of those chat on Up to Date were on the chat. So why not directly talk to the authors and the experts? And the themes that emerged from this were collaboration, patient care, and knowledge sharing. Okay, so anytime you have a very rare subspecialty, it's good to create these mastermind chats and get the people who are like-minded together and share collaboration and cases that could help your patient and also create research ideas. So a lot of this has come out of because of this chat that was created in 2019. What about education on nephrology? So there is something in the 2 years of your nephrology fellowship, you can do something called tracks. So this is a new ASN sort of initiative so that people prepare for some subspecialties within nephrology. So if you have the topic experts in your fellowship, so you can actually create a track within the 2 years and spend more time with those topic experts and do extra clinic and so forth and do an onconephrology track within the 2 years of fellowship. Okay, that is there, and a lot of people are trying to do that. We have done that for 7-8 years, and we've had some fellows just do the track. But you have to have faculty that's expert in it and a way to design the track that does not distract you from the general nephrology fellowship. There's pros and cons to that. Or you can do an extra year of fellowship in after nephrology. So that's now a third year of fellowship. And that is being offered by MD Anderson, a cancer center, Sloan Kettering, a cancer center, Toronto, which is not a cancer center but has a division, UPenn, Mayo Clinic, and us. Okay, so these are the only so far fellowships that are available. They've been there now for many, many years that offer that extra year after fellowship. You really want to do academia, want to get more into academics and publishing and truly advance the field. You can get a job as an onconephrologist in a private practice or anywhere by doing the tracks as well. Either way is fine. It depends on what you're looking for. and how you want to advance the field versus what your career as well. So this is our fellowship. It's the Galdi one-year fellowship in onconephrology and glomerular diseases. It's a combined glomerular disease and onconephrology, because I think those two are very tightly knit, and we borrow from each other's treatment and treatments. So we have integration of oncology and rheumatology in our rotations, a nephropathology rotation and research track along with the clinical volume. This is one of our first fellows who graduated, Rosemary Attia. And these are our donors, Mr. Galdi, who actually funded this whole fellowship. And, this fellowship exists because of him and his wife. Rosemary Attia was our first fellow. She's at Mayo Clinic as faculty now. Gashu Ayayu is in pharma, and he's leading the large trials in C3G. Krishna Kurawara just opened an onconephrology clinic in a center in University of West Virginia. And our current fellow is here from UConn. And just started in July. What is American Society of Onconephrology? That was founded in 2021 by Araj, Biru, Shruti, and myself. And this was really to promote the whole field and get more traction. We started discussing this in 2021. We had our first meeting in 2021 October, and then we filed for a 501c3. We developed a logo, and we created a website. And then it was not till 2022 when we incepted the whole organization. Actually, to help create the website, the logo, we had a lot of college students help out. So kind of similar to what you guys are doing at UCLA, a lot of hard work went into these initial years. And then the creation welcomed members in January 2022. And now it's going really strong 4 years later. And we have multiple committees. We have position statements. We have websites, design, social media statements, partnership with industry, and ASCO, which is the Oncology Society's monthly educational series, and yearly host of an onconephrology symposium. This year is in Boston at Dana-Farber. Last year was, I believe, it's in Mayo Clinic. So there's rotations that happen every year. So with that, I will end and take questions in the last 5 minutes, but you guys can email me. That's my blog. And I know there is a slide that I need to make sure you guys see this as well from Core Kidney.
Yep.
I'll take questions, Sanjay.
Yes, Dr. Jhaveri, amazing. As always, so much information in this 50 minutes. Dr. Wadhwani, our GN guru, says hi to you, Dr. Jhaveri. So she's here as well. Now, just a few things. I think there are a few questions coming in, and a lot more will be. That was interesting about this high school student putting that together, that WhatsApp data. So that's quite fascinating. I think there's some ideas for our Bruin Beans as well. And just a side note, you have that logo for ASON or ASON.
Yeah.
What is that? A tornado coming over here, or
This one, no, these are all the ribbons for cancer.
what
No,
is
this
it?
is not the logo. The logo is up here. That's the logo for ASON.
Right.
This is our full logo, but these are all the cancer ribbons of different color
Oh, wow, that's
and in
beautiful.
the shape of a kidney. Yeah.
Wow. And what is that other one that you just showed?
Oh,
That
that's just from Google. It's just an
Oh,
idea starts in the small and
yeah.
goes up. Yeah.
So, first of all, congratulations on this innovative. It took a lot of work and some time as well, but looks like you're on track now to huge success and inflections. Now, when we talk about onconephrology or any of these fields, even GNs and other, it's multidisciplinary rounds, right? Or multidisciplinary teams. How did you get the buy-in from oncology? And how much is there a buy-in from oncology at your own institution?
A lot. So I think initially when I started in 2009, I think a lot of it is you have to go give talks to them, reassure them that you're interested in their patients. A lot of their patients are very complicated, and you don't want to just see them in 10 minutes and that's it. A lot of these patients take almost 30 to 40 minutes of time, an hour sometimes. So you want to show that interest because you have to be passionate about the field to do that. And then also to show them that the field is evolving and there's data that might help their patients to prevent this injury or catch it early and treat it, rather than do nothing about it. So I think that's where the buy-in comes in. And because a lot of it is also just getting to know and building that practice.
Mhm. So, are there joint clinics, Dr. Jhaveri, for this, that the oncology and nephrology see patients together?
You don't need to. You can have as long as you can get the patient in a timely fashion. I don't think the oncologists care where you see them. Um, so yes, you can have a clinic in the oncology cancer center, and that's fine. Just keep in mind that you're not going to have your microscope to look at the urine. You're not going to have your office secretary, your office hours. It's
Yeah,
going to be a little. So it's a pros and cons to both.
yeah.
If I do it in my office, I can see the patient any day, anytime. If it's their office, I have a dedicated clinic time and I won't be able to see them outside that time. So you have to weigh those risks and benefits and decide what's best for you.
And because a lot of times, even in our own clinics, it's all about, trying to minimize the number of appointments. But then there's also the like you said, the con side of that all these limitations come in. And for any multidisciplinary team, both will need to be kept in mind.
Yeah.
But
But I think a lot of these patients require urgent evaluations and availability and the knowledge. So it's very hard to get all three because you may be available, but you don't have the knowledge. I can have you see any nephrologist, but if they don't know anything about these new drugs and
right.
stuff, it's going to be a pointless visit for that patient and the oncologist. So I think that's where the biggest challenge is.
No, I'm going to come back to that because I think that's really where the expertise really comes in. But for oncology, are you seeing even like primary prevention? Are they doing routine kidney health screening like UACRs when the patient comes in?
So for certain drugs, they are. So now most of the oncologists are very aware of um, sort of the proteinuria risk in certain patients. So they will check a baseline urine, a baseline creatinine, for example. And some of the oncologists who know the literature well are checking cystatin CGFRs in the right those drugs that I talked about. So, they are being proactive. It depends on the oncology group and the oncologist too, and the type of cancer they're treating.
And once again, talking from an institutional standpoint, Dr. Javeri, when, it has to be a bigger healthcare system, it's freestanding and sometimes difficult to put those resources in and the expertise, right? The reality is it's still rare, right? The onconephrologist.
Correct.
Uh, uh, how many other people besides you actually are part of the practice for
So
onconephrology?
Onconephrology, I have three people, three to four, actually three and a half. So I don't believe in doing it solo ever. When we started, I always you have to have partners in crime. Otherwise, coverage becomes a concern. You will be burnt out. You want to have, and you also want to groom other people. So you don't want to just do everything yourself. So we have two of us who are senior who do most of it, but we also have two other who are sort of junior faculty who are kind of learning the ropes. And then we have a fellowship now. So we also have a fellow who's just dedicated on GN and onconephrology. So, we have a group now. And I also have a nurse practitioner that is helping with the ancillary stuff. And I can also see patients because she's good to has seen enough patients now with this problem.
Now, but your other pet fellowship. So I think and you showed your fellows, they looks like they're getting good positions. One went to industry, others at Mayo Clinic. Um, so, I mean, this is obviously a very niche field at this point, and hopefully it won't be because cancer is very common, right? And kidneys get affected. So how are you doing with the recruitment? In nephrology, in general, it's tough, right? I mean, we're lagging behind. And this is another year of fellowship. Are they as faculty members, junior faculty, and this is not ACGME accredited at this point?
Correct. So it's a non-ACGME fellowship anywhere. Okay. But when it's non-ACGME, there are two routes. You can do a fellowship, a true fellow, or you can do a junior faculty. So it's a fellow. So they're under the graduate medical education. So it's a fellowship under the graduate medical education. So they have the full fellowship benefits, the visa benefits, and the work hours. So they function essentially as a fellow. We prefer that route because then you can get you can get top-notch fellows that are not even, that could be international perhaps or have visa that want to still come and do these fellowships, as opposed to junior faculty. We're not allowed to have certain visa requirements, and there's no scrutiny over that. So we rather have a full fellowship. So it's, that pros and cons to that. So no approach is wrong or right, but it's just it's a lot more paperwork to do it this way. I have to fill out probably monthly paperwork evaluations. You have to do yearly evaluations. It is a slightly harder approach, but I feel it's more robust and cleaner. It has a track record. Um, the junior faculty approach, you don't have much, leeway there. They're kind of a free bird, do whatever they want. Here,
Yeah.
there's more supervision. Yeah.
Yeah. And also, if they're junior faculty, then they have other commitments, right?
Well, then
As
they'll have RV requirements.
yes.
They'll
Yep.
have they'll
Yep.
have to do general nephrology rotations, which is then defeats the purpose. Yeah.
Yeah. And your fellowship is combined with GN, so they're getting two
Right.
things.
Yes, correct. Between in one year they'll see a volume that is, really good in terms of both GN and onconephrology, and it's mostly outpatient based. We do inpatient only as needed if there's a second opinion needed or extra help by the general nephrology team, and that's how we use the inpatient part. But most of their work is outpatient and research.
Yeah, and I think this is going to be the future, with I mean, when people graduate with these advanced training, I think they will. And we talk about normally about big academic programs, but we are seeing that with transplant now as well.
Hmm.
There's so many transplant patients, they need a transplant trained faculty or provider. So I think this same thing with GNs, that's obviously a very, very hot field. And onconephrology is next. And if you have combined training in both, you're golden.
Yes.
I think people will
Just
create positions.
Yeah, sorry, Jay, but just to remind people that you also have to pay the bills. So, just I always tell fellows is just because you did an onconephrology or GN fellowship, the job you're going to get will still require you to see dialysis patients, still
Yes.
see, um, you know, um, sort of general patients, because you have to still get enough your revenue to generate an income. Onconephrology alone or GN alone is not going to do that. So just so that the realistic picture sets in, it's important to have this expertise as your niche. So
Yeah.
you see majority of these patients, that are this. But I still have dialysis patients. I still do general nephrology consults
Yeah.
because I still have to go home with a paycheck, right?
Right.
So it's important that people realize that and not have this dream thing, oh, that's all I'm going to do.
Yeah.
It's
Oh,
not,
no.
it's
Yeah.
not possible. So for the students and the residents and the fellows, it's important that they be realistic when these decisions they make.
Yeah. And also that same things like interventional nephrology. I mean, even though they're interventions, it's 1 day per week. The other 4 or 5 days they will
Correct.
like patients and just like but it can also be a very niche that as it grows in importance, I think will get busier and busier. You know,
Correct.
There's so much need. And
The
like you
other
said,
thing, what we do is to decrease our volume because I don't want to see every onconephrology patient, right? Because there's some straightforward stuff that a general nephrologist should be able to handle. So we let the general nephrologist see most of them if the complicated ones come to us now. So if they need help, then we get involved. So that way, you also are training the general nephrologist to see these patients as the volume of cancer patient grows.
yeah.
So it's important that you don't funnel everything to yourself. Again, I'm big into work-life balance. So I think it's important that these things are really streamlined so that not everybody gets slammed with these funneling of all these patients, whereas as you become sub-specialized.
Yeah. And all the educational programs that you're doing will help people understand that better. So they hopefully
Exactly.
will be able to answer that. So I think that was all the questions that I had. I think we're over time. I just want to see if my beans have any questions, the brewing beans for Dr. Jhaveri. And if
Hopefully it was
not,
not too complicated for them. I know they're an undergrad, but I tried to simplify it.
yeah. Alicia, Arif, Evan, anything for Dr. Jhaveri right now, or you can reach out to him as well.
We will be happy to reach out to Dr. Jhaveri. Thank you so much for your presentation thus far. I believe we weren't fully aware of the connection between onconephrology and a nephrologist and how they should really have a dynamic equilibrium when it comes to working with these specific niche type of patients. So we really appreciate the perspective you offered for us today.
Thank you.
Great. So with that, we will end this grand rounds. Amazing. Thank you so much, Dr. Jhaveri. I'm seeing all these comments that are coming in, and this is recorded and it will be posted on YouTube and it will be shared on LinkedIn and everything else. So with
Yeah,
that,
if you're an oncologist or anybody have questions, they can email me.
yes, there is a lot of interest from them. So I am going to connect you. They have your information, Dr. Jhaveri, but if not, that would be
Okay.
very nice of you to connect.
All
So
right.
with that, we conclude our grand rounds for today, and thank you very much for attending.